Welcome everyone. My name is Marielle Malana. I will be your host for Global Ground Rounds with Global Offsite Care for today. Today's presentation is CME approved, so if you would like to receive CME credit for this presentation, please click the link in the chat box. And now we have our Global Offsite Medical Director here, Dr. Pacquiao, who will now be introducing our lecturer today, Dr. Hruby.
Thank you, Marielle, and both to you and all of the staff volunteers that support Global Offsite Care, in particular Global Ground Rounds, and we really appreciate your work. And thank you for setting this up today along with your cohorts. So today we have a welcome return of a previous speaker from the past year or two, Dr. Ray Hruby. DOMS FAAO. He is a member of the Department of Neuromuscular Medicine and Osteopathic Manual Medicine at Western University of Health Sciences in Pomona, California. Dr. Hruby was professor and chair of the department there for about 10 years and retired, quote unquote, from his that position, but continues to work at Western U as a professor and consultant to the Department of NMM and OMM. He's involved with teaching, research, curriculum analysis and development, and mentoring of new faculty, as well as pre-doctoral fellows in that department. He's also involved with Western U's interprofessional education program, and his upcoming presentation today is on the lymphatic system, giving an osteopathic view of that system and explaining the clinical implications, including some of the challenges of recognizing that and implementing treatment protocols specific to that in the virtual environment. So with that, Dr. Hruby, the floor is yours, and thank you again for joining us today.
Okay, thanks, Dr. Pacquiao. I'm going to share the screen here. Okay. I can't see everybody else now. So.
Right. Looks good. Looks good.
Yeah. Okay. So as Dr. Pacquiao mentioned, we're going to, I call this the lymphatic system an osteopathic view, in that I think there's some perspectives on the lymphatic system, among other things, that the DOs bring to the table. And we'll talk about that this morning and show some of the applications of it, and at least get a little bit of an insight into this. My standard conflict of interest, non-disclosure slide. So hopefully by the time we're finished discussing this morning, we'll be able to have people be able to not only kind of have a little refresher on the lymphatic system itself and what it is, what it's made up of, and how it functions, but to also look at least a couple of things from an osteopathic point of view. One is we talk about somatic dysfunction in osteopathic medicine, and I'll talk about that a little bit in the presentation too. But somatic dysfunction, when you see an osteopathic physician putting their hands on a patient and doing a structural examination and finding what we call somatic dysfunctions, or various restrictions in the musculoskeletal elements and structural elements of the body, and treating those with osteopathic manipulation. That's what we're talking about. And those kinds of somatic dysfunctions do a lot of things to people, and including anywhere from the obvious things of pain and discomfort in areas that are restricted, not moving well, to affecting physiologic functions sometimes, altering the normal functioning of the autonomic system in some ways. And in our case, we're going to be talking about how some of these somatic dysfunctions can sort of, if you want to use the words, impair, impede, or somehow adversely affect the maximum function of the lymphatic system, particularly the flow of lymphatic fluid throughout the body. And we'll talk about how that, how we think osteopathically about that in terms of everything else that we're doing for a patient. There's some things that we can do with our hands to access the lymphatic system and its functions, and utilize that to help promote healing and more rapid recovery in patients in certain conditions and more long-term recovery sometimes. And we'll talk a little bit about these applications as well. So one of the things I like to do is maybe give a little definition about everything that we're talking to. Maybe I've been in academia too long, but from a kind of a functional standpoint, I think of lymphatic system as part of the circulatory system. I also get the opportunity, among other things, every year to give a presentation about applying osteopathic principles to cardiovascular system and cardiovascular conditions. And so I like to define that too. And it was interesting when I prepared for that particular presentation some years ago, just looking for a definition of the cardiovascular system. It's not exactly written in stone, defined. And so some people in the cardiovascular system, for example, include the heart and the arterial system. Some consider the heart, the arterial system, and the venous system. And sometimes I think actually from an osteopathic point of view, we take a step maybe a little bit further back and say, well, let's not talk about cardiovascular system, let's talk about circulatory system, in which case we can have some effect on all of these fluids that can circulate through the body, and are they circulating properly and at their optimum best now, or can we help that to be restored and recovered and maybe augmented in some cases, as we'll see as we talk about it. So we're really talking about this idea of remembering, I think Dr. Pecchia mentioned it and as he was introducing me, that we can, as we'll see here, affect the lymphatic system with the use of our hands and our ability to do structural diagnosis and treatment, and to affect any interactions in the body that might be affecting lymphatic system function, and use that to our advantage in taking care of patients. And you'll see as we talk about them and talk about the procedures a little bit later on, they're not difficult procedures, and many of them can be taught to patients to do some self-treatment, can be taught to family members sometimes, some of the simpler techniques to help people in their process of recovery and improvement from different conditions. And they can easily be added into the care of almost any kind of patient, depending on what our goals of treatment are. So it's something to keep in mind because it's very easily accessible and very easily done. In addition, I want to just mention real quickly that, we're kind of excited in the osteopathic profession, as many other people in the world of medicine are, about discovery in recent years of what's called the lymphatic system. That is a lymphatic drainage system from inside the cranium, from the brain. And as we all know, if you've heard of this, that up until those recent years, somewhere around 2012 or so, I think, maybe give or take, there was a lot of thinking that there wasn't a lymphatic drainage system in the brain or inside the cranium, but yet now we know that there is. As DOs, actually, among many other kinds of manipulation we do learn certain techniques that we actually apply to the head and neck area, and part of at least the theoretical underpinning of using those techniques was the clinical effect of seemingly of being able to improve venous, lymphatic, and arterial circulation in these areas that helps people to recover from any ailments that are going on there. So now we know that we have this lymphatic system, which includes these meningeal lymphatic vessels. And our techniques, now it remains to do some measurable research to just kind of hopefully fill in the gaps of what we think is going on with these techniques. in that area, but we think we'll be able to show that fairly easily once some of this research work gets done. And we'll then have all the pieces together for what kind of we've been doing on a clinical empirical basis for a long time. Be able to show the mechanism of action that's going on here a little bit more. So we've had, as I'll mention later on, a lot of research over the years that seems to demonstrate and support what we're doing with our hands in other body regions. And so this lymphatic and meningeal lymphatic system, another exciting area for us now. So again, to just kind of define it in another way, we think of lymphatic vessels, organs, and lymphatic fluid. I put this in there because when we get to talking about some of the hands-on work that we're doing, we are particularly looking at these areas. We have techniques, and I'll be able to show you a video later on that'll demonstrate at least probably one of the most commonly used techniques in many conditions with patients. But there are techniques that are directly applied to that are meant to augment the flow of lymphatic fluid throughout the tissues of the body. There are techniques that are meant to restore what we call physiologic motion in areas of the musculoskeletal structural supportive system of the body that would allow for better, more optimum flow of lymphatic fluid through these areas. Keeping in mind that the lymphatic system does have what we call an intrinsic and an extrinsic pumping kind of system. The intrinsic system has to do with the actual innervation of the lymphatic cells and vessels themselves, particularly through the autonomic system, that allows for an actual intrinsic contractibility of the lymphatic vessels, and the movement of fluid in that fashion. And the extrinsic system, which we all are pretty much aware about in the system, and that is that basically the bulk of our lymphatic fluid is moved throughout the body on a day-to-day basis through respiration and through the function of the musculoskeletal system. So every time we move, the contraction and relaxation of muscles throughout the various body regions is one of the prime movers of fluid through the system. And one of the prime pumps is the thoracoabdominal diaphragm. So you'll see that we have techniques that we can address any of these body regions this way, with the goal of improving the flow of fluid through these regions back to the central circulation, and also by way of removing any somatic dysfunctions, if you will, the restrictions that we look for in these systems. The idea is that we restore the physiologic motion in those areas so that the body's own mechanisms take over for the patient, so that in many instances clinically, and we'll talk about some clinical applications later, the ability to do that and restore this thing can make a dramatic effect in the patient's outcome. And by way of restoring the patient's own inherent mechanisms, it should be more long-lasting and not require repeated efforts on our part as we restore the body's own ability, which is one of our goals in osteopathic medicine. One of our tenets is that we understand in this fashion the self-healing and self-regulatory capabilities of the human body. And so we want to augment that and to restore that and keep that as optimum as possible in the patients. And the other goal we'll see more directly in one of the slides is to not only to just restore this, but also to we can create an immune system effect by way of impacting the lymphatic system this way. And I'll mention some of the research that's been done to show that this can be done. So once again, just a little visual here to show us this is what we're kind of working with. It's showing some of the more superficial areas on the body, but also some of the deeper areas, as you see some of the labeling on here. So just again, to remind us of the system that we're all familiar with in one form or another, and areas that we can have an impact on the patient. So some of the functions, of course, we've kind of mentioned them a little bit here, and that is, we want to reabsorb and return the excess interstitial fluids back into the circulatory system. And that's what goes on by the normal day-to-day functioning of the lymphatic system, by the movement of the body, by the musculoskeletal system, by the effects of respiration, and the thoraco-abdominal diaphragm in particular. These are some of the extrinsic factors that move fluid. And then, of course, there are some, as I mentioned, some autonomic innervations to the lymphatic vessels themselves that help to have a kind of an intrinsic movement system to move fluid through the system. There are some specialized areas. I didn't mention everything here in the slide, but just quickly mentioning the lacteals, which are the capillaries that are in the villi in the small intestines, and they serve a function of absorbing fats and fat-soluble vitamins, for example, and this type of thing. We tend to be, we understand that part, and in certain conditions work towards that goal. More commonly, you'll see that we're looking at trying to influence the lymphatic system through our hands-on work to, again, to restore a proper flow of the lymphatic fluid so that it can use its immune system capabilities to help the body get well and stay well, and also to relieve areas of edema and other things that go on in certain conditions. And again, affecting the immune response, I think we said. So, and one more time, so the somatic dysfunction, without going into a whole tutorial on somatic dysfunction, this is the definition that's given in our glossary of osteopathic terminology. So the impaired or altered function of the related components of the somatic or body framework system, which includes the skeleton, joints, myofascial structures, and their related vascular, lymphatic, and neural elements. So put this in there just to remind us that that's the official definition. It's very noble and academic, I guess, if you want to call it in that fashion, but also to remind us that a lot of times people look at osteopathic manipulation and think, wow, that's really great if I have a headache or back pain or things, and it is. It's a nice treatment approach for these things, but it is not only about manipulating muscles and joints. It's part of the whole approach from an osteopathic viewpoint is to not only affect motion in those areas, but to influence the physiologic systems of the body as well, and keep them as optimum as possible. So we kind of think that, almost any disease or condition that a patient can present us with would have a somatic component related to it. And indeed, we've certainly shown that over the years with various research projects. For example, someone who there have been specific palpation research studies done with inter-examiner reliability studies to show that DOs who are trained in this hands-on approach can do a structural evaluation on patients, and particularly if we look at the thoracolumbar region in the spine, where all of the autonomic or the systematic or the sympathetic innervation comes from, and we know from the cranial and sacral areas the parasympathetic innervation. As we detect these somatic dysfunctions in these paraspinal areas, we can relate them segmentally to the internal organs that those autonomic innervations also affect too, so that if someone is, for example, suffering from a peptic ulcer, then we know from the somatic dysfunction findings on most of these patients that they have associated somatic dysfunction in the segmentally related areas of the spine, like, particularly in the areas of the greater splanchnic nerve, T5 to T9 area, roughly in the paraspinal regions. We can palpate those dysfunctions. The patient has a peptic ulcer. They need treatment, as we would all understand, treatment that would involve medications, dietary changes, lifestyle changes, all the things that would go into needing change because they probably contributed to producing that problem. But we also know that those somatic components, the somatic dysfunctions segmentally related to that, should be treated. It removes the tension in those segmentally related paraspinal areas. It calms down the sympathetic input to that region, achieves a better sympathetic parasympathetic balance in the system. And so we think that this somatic component is large enough and important enough in almost any condition, and that it contributes to this problem that the patient is having, and it needs to be treated as part of the whole treatment of the patient. So we think of that somatic dysfunction and that component, somatic component, if you will, as part of what we'd call the allostatic load on the patient. It's one of many stressors that is contributing to the patient's problem. And so we want to alleviate all of these as much as possible. So we're thinking of the same thing in terms of lymphatic system. What are the stressors and allostatic problems that are, causing less than optimum function of this lymphatic system, and how can we have an effect on it? So again, I think I just said everything that I said on this slide just a minute ago. So any of the somatic dysfunctions that provide these kinds of motion restrictions, particularly when we talk about the abdominal or even the pelvic diaphragm, there needs to be, by the way, a coordinated motion with respiration and the movement of the thoracoabdominal diaphragm and the pelvic diaphragm in a synchronous fashion. And that is the most effective way for that pumping mechanism to move fluids, including lymphatic fluids, throughout the body. And so we're concerned about being able to make sure that those particular areas move well and properly, that there's proper rib cage motion. So any restrictions that cause less than optimum movement of the rib cage contributes to the adverse problems of the patient that's going on. And it may not look dramatic, but sometimes adding this treatment into everything else with the patient can make a dramatic improvement, particularly in patients that sometimes have some very advanced problems. Also, this usually involves more illnesses or diseases that might actually affect the lymphatic vessels themselves, and it might alter that autonomic functioning that goes on for that lymphatic intrinsic pump in that area too. So our goals then are we want to take away this somatic dysfunction to return the physiologic movement of lymphatic fluid through these affected areas. And we want to restore that. We want to make sure it's as optimum as possible. In some cases, we use the techniques to actually augment the flow. You might say that, well, there's not a lot of somatic dysfunction, if you will, in a patient here, but there might be ways to actually, at least for the time being, augment some of the flow. And so some of the techniques that we use are used in those conditions. I'll jump ahead at the moment right now, but come back to some of these clinical situations. One example particularly is, for example, the post-operative patient, or a patient that might have an acute problem, like particularly respiratory ailments are good for this. So the patient has an upper respiratory infection or a pneumonia, using some of the lymphatic techniques that, so they may not have necessarily a lot of somatic dysfunction. A post-op patient might be recovering just fine from a surgery, but we sometimes add some of these treatments to them in order to make sure that the fluids are moving properly in the body, the tissues are getting proper arterial blood and venous return, and getting lymphatic flow to them, along with all the immune effects of that. And so it can assist in the more rapid recovery of patients, and it can by restoring the movement of all those fluids, or making sure they're working as optimally as possible. We know that this has been shown through a few studies to show a marked reduction in these patients of getting things like post-operative pneumonia or pulmonary embolism or deep vein thrombosis. We use these techniques as preventive medicines to some of these problems too. So starting to look a little bit more clinically here now. Looking again at this, you can see a little sort of mapping out of the body here. You see the upper sort of right quadrant of the patient here, if you want to call it that. It's a little bit of a light green compared to the rest of the patient. It's not green because he's dying of some sort of decomposing disease, or it's just a color to enhance this idea. So from a clinical standpoint, when we look at the patient osteopathically, we just try to remember ourselves clinically that whole area that you see, the whole right upper extremity, the right side of the chest area and up into the right side of the head. That's a whole area that's drains through various lymphatic channels and nodes, eventually into the right lymphatic duct, into the subclavian vein on the right side. And that's where it all ends up getting back into the central circulation on that side. Everything else in the body, the entire left side, including the entire lower half of the body, eventually drains into the thoracic duct, which empties into the left subclavian area. Okay, so just as a clinical point of view, we keep that in mind. So looking at the patient and looking what their clinical condition is and what their status is at the moment, and if they have edema, for example, part of their condition, where is the edema? What parts of the body are there? And so where do we want to treat? Where do we actually want to put our hands on the patient physically, try to maneuver these tissues and begin to restore this optimum flow of lymphatic fluid? And so it brings about that there are no, in school, the students, and we all do, we do the same thing. We use the language lymphatic techniques. We have different types of OMT technique. And so we always refer to lymphatic techniques. In truth, there are only a small number of our techniques that directly are working on the lymphatic system itself. And you'll see some examples here in a little bit. But in theory, any type of somatic dysfunction can have some slowing down or adverse effect on the flow of fluids, at least through that body region, if not more in depth. And so any type of OMT that restores the proper muscle tone, restores proper joint function, restores the ability to have the body to have its physiologic motion intact, can be used to affect the immune system. Although there are a few techniques that go directly to the movement of the fluid itself. And we come on to the idea of using treatment protocols. Now, we have what we call a lymphatic protocol that we teach. And in general, we don't teach, it's not that we don't teach them, but in general, we don't think too much about protocols, if you will. In terms of OMT, most osteopathic physicians, there are certain things that you can recognize clinically and know that certain treatments would be the best use of them. But for the most part, we tend to do structural evaluations on patients, locate the areas of somatic dysfunction wherever and whatever they might be. And knowing that this is part of a body-wide system, we tend to treat those regions with the goals of improving the physiologic functions throughout those regions for the sake of the entire body. If for no other reason that it takes that energy drain, if you will, that increase in allostatic load off the patient. So anytime the body's physiologic motion is not at its optimum, the body needs to expend more energy to try to adapt or compensate for that. So if we can reduce that energy demand on the body, then the patient has more of that energy available for recovering and healing from whatever their other conditions are. So that's at least a broad goal that we can have with that patient. There is a certain real value in using a kind of treatment protocol, as we'll see in a few seconds here, with the lymphatics, because it should be done in a systematic kind of fashion. So on the one hand, we don't always look at just applying protocols to the patient, because every patient is different, and even the same patient is different on different treatment occasions. And so clinically, as DOs, we don't tend to treat patients by protocols. That's a little bit like, I know the old joke I used to hear, if you're unsure of yourself, go into your office in the morning and open up the cabinet where you keep all your pharmaceutical samples, and then you'll know what you're going to diagnose every day, all day long. Okay, so we don't prescribe the same prescription for every patient. These types of things, everybody's treatment is individualized. But in terms of lymphatic system, it gives us a more structured approach to looking at what we're doing. And you can see here one of the first broader principles that we would treat what we call the more central areas of the lymphatic system first, and then go out and take care of the more regional, more peripheral areas that need attention. So in this area, and we'll come back to an image of this again, so you'll see it a little more visually. The first thing we do when we want to work with a patient with the goal of improving or augmenting this flow through the lymphatic system is we treat what we call the thoracic inlet. Now, the thoracic inlet is what we all learned in school as the thoracic outlet. And in osteopathic medicine, we tend to look at that area as a thoracic inlet relative to the lymphatic system, because as I showed you in the other images, this is where eventually all of the lymphatic fluid coming from the periphery back towards the central circulatory system ends up being moved into that system through the right or left subclavian veins, through either the right thoracic duct or the primary thoracic duct on the left. And so regardless of if we have a patient that just simply has edema in their lower extremity somewhere, we want to make sure that those thoracic inlets are looked at, and that any restrictions in those areas are taken care of first. So that would include any type of hypertonicity in the soft tissues in these supraclavicular fossa areas, checking the upper rib cage, particularly the first rib area that you can palpate in that fossa on each side, and making sure the upper ribs are moving symmetrically and as well as they should, because that respiratory effort in that region is going to be one of the major efforts that helps to move fluid through that area, and helps that so that helps to keep that final area there as the thoracic inlet on each side there open, as we call it, so that the final terminal flow of the lymph into the central nervous system in that area, it is at its best. Those areas are open, so there's a place for all that fluid to move to when you move it towards that area. And then some people look at what we call spinal transitional zones, and I mentioned them here. The craniocervical area, the cervical thoracic junction, C7T1, craniocervical area, meaning the occipito-atlantal and atlantoaxial joint areas in those regions, thoracolumbar region, T12L1 area, and lumbosacral region, L5S1 areas, to be segmentally specific about them, so that we make sure that those are areas of transitional zones, as we call them, because they're areas from one spinal region to another. They're areas of pivotal movement in the spine, for example. And so there's a lot of activity there that can affect the generalized motion throughout larger parts of the body, and some of the more physiologic functions that we need to have in place for lymphatic flow. For example, the thoracolumbar region is the same area where we think of that as the T12L1 area. That's also the area where the thoracolumbar the thoracoabdominal diaphragm is located. The central attachments are in that region. So any restricted motion in those vertebral segments, for example, could have the effect of not allowing the most optimum movement of the thoracoabdominal diaphragm, for example. So we want to make sure all of those bone and joint regions and rib cage regions are moving as optimally as possible so that these other tissues can be optimally physiologic in their motion. Okay. So treating the inlets, as I mentioned, is the first thing that goes on. Secondly, we can look at either these transitional zones, or another way to look at it is to treat what we would call the extrinsic pump. And that usually most people refer to that as the thoracoabdominal diaphragm, meaning that's the major muscle that functions to help with thoracic respiration and to move a lot of the lymphatic fluid throughout the body, throughout the day. So we want to make sure that the thoracoabdominal diaphragm is working properly. We want to make sure that the pelvic diaphragm is working properly. So there are techniques that we have to palpate those areas, make sure that when the patient breathes in and out, those tissues move in the directions that they're supposed to move, and they do it synchronously. When we talk about the cranial-cervical junction, that's also the area where we know internally, it gets into all of our talk about cranial treatment on patients, a little bit beyond our scope today, but we can think of the tentorium cerebelli inside the cranium as a kind of diaphragm in itself. So it does have a very subtle but physiologic motion to it, and so it functions a little bit like a diaphragm in a kind of contract and relax kind of motion, and so it contributes, we think, probably to relating to how spinal fluid is moved around inside the cranium, and how now we think it's going to be related to how the lymphatic system and the meningeal lymphatics help to restore and move fluid through these systems. So we would do these things this way, and then we would treat the myofascial restrictions in all of the pathways from the extremities into the ones that are involved, at least on the patients. And then there are some areas that tend to collect fluid, like around the ankles and the posterior patellar regions in the legs, things like that. So it's a little bit of a map for some of these regions. Again, our thoracic inlet up in here, around the pectoral, the axillary folds is another area that collects fluids. Sometimes people have fluid in the abdomen. Up in this area, we have inguinal regions, and down here we have our popliteal spaces and Achilles areas. So some of these areas get congested along with the extremities themselves, and so we can, once we have any of the central problems taken care of, the thoracic inlets are open, the diaphragms are moving, then we can go to these other regions and work specifically to treat anything that's we can see that needs to be addressed clinically in those regions. So again, this is just one more map to show us what we're talking about here, and we can kind of move forward with this. So this is, I'm going to show this. This is about just about 6 minutes, and I think we can do that really quickly and have some time left over from the discussion. This is one of many things that we call lymphatic techniques. This is what's called a thoracic pump technique, and it's a technique that's used for anything from respiratory infections again, as a general technique to move fluids throughout the body. Some of the other clinical conditions are, well, I've mentioned some of them. Respiratory problems, pneumonias have been studied with these types of techniques. Post-operative patients might be perfectly fine post-op, that is, they're recovering perfectly fine. We sometimes use this technique as well as some others to make sure that their body fluids are moving properly, particularly lymphatic fluid. And for that reason, for two reasons, in a post-op patient, there may not be somatic dysfunction associated with these things, but if there are, it helps to alleviate them, and it helps to move the fluids properly. It helps to augment the movement of fluids, particularly lymphatic fluids. So with a post-op patient, these techniques have been used and some studies have shown you get a clinically reduced chance of getting something like a post-op pneumonia or a pulmonary embolus or deep vein thrombosis by keeping these fluids moving properly. At the same time, you do have an effect on the lymphatic system. And so even that effect, even in a normally recovering post-op patient, it may enhance their recovery ability. We see sometimes where people are up and out of bed quicker, go home sooner, things like this. So we are addressing the osteopathic tenet that says that the body has self-regulatory and self-healing systems, and that we have at least this one approach that we can use with our hands-on techniques and our osteopathic thinking to help augment that self-regulation and self-healing in the patients. So let me just play this real quickly, and then we'll finish up here. This is one of many videos that we have for our students to review and use as well as their hands-on lab techniques as they're learning this through the school. And you'll see in this video Dr. Rebecca Giusti, who is our well, I'm just going to say it. She is a former student of my own when I came here to Western University, who is now in the job that I hoped she would be in these days. She is now my boss. She is our department chair. And this was one of some videos that she made to demonstrate some of these techniques. So this will give you a taste of at least what one of these techniques looks like in approaching patients. This is called the thoracic pump technique, of course. And if I can keep my fingers on the right button here and press it. I tried to enlarge the screen and I screwed it up. So
in order to position my hands for a thoracic pump, we'll be finding the area just distal to the clavicles with the thenar eminences and hypothenar eminences of the hands. We will add a little bit of posterior pressure and inferior pressure to those hands for the appropriate contact. I will now be administering the classic thoracic pump to my patient. Within the lymphatic protocol, we would have already done the thoracic inlet release bilaterally in order to free the thoracic duct and the right lymphatic duct. Next, we would have wanted to address the thoraco-abdominal diaphragm in order to improve overall lymphatic flow through the body. The thoracic pump may be used as a finishing technique. An indication for this may be an upper respiratory infection, pneumonia, COPD, or other respiratory problems that the patient may be encountering. In order to perform this technique, I want to ensure that I assume a type of lunge stance with my lower extremity so that I have a stable base in which to perform the technique. I will be contacting the area just distal to my patient's clavicle on the upper chest with the thenar and hypothenar eminence, with the majority of the palm over that upper pectoral region. I will ask my patient to breathe normally. Okay, and from here, I will be administering a vibratory or oscillatory motion at about 110 to 130 times a minute. This will come from my entire body, although you can see the motion is very slight. We can notice that the patient's feet are moving slightly with this rhythm. My hands and wrists and forearms are locked, and there is just very slight flexion extension of the elbows in order to perform this oscillatory motion. But again, I am using my whole body to do it. My shoulders are relaxed, so I could perform this technique for about 1 minute to 2 minutes, or until I feel the desired effect, which would be increased tissue compliance and softening of those tissues. Once I have that end point that is desired, I can take my hands off my patient. An objective way to measure if this technique had been effective would be to check the patient's O2 saturation. Sometimes the patients will subjectively report that they're able to draw in a deeper breath. If my patient was a female, and perhaps a female who had particularly large breasts, in performing the classic thoracic pump technique, for the patient's comfort and perhaps for the physician's comfort, I may ask my patient to actually cover their chest region as long as they're clear, their hands are clear of the upper pectoral region where my palms need to maintain contact. If it is a female, they can slightly draw the breast tissue inferiorly towards their feet. From there, I would be contacting the area just distal to the clavicle with my hypothenar and thenar eminences. We may notice that my finger pads will be resting lightly on the patient's hands. would assume my lunge position, and I would now perform the technique for the patient to their comfort level. I will now be performing the variation of the thoracic pump on my patient. In this technique, again, it is part of the lymphatic protocol. We would have already addressed the thoracic inlet released bilaterally to free up the thoracic duct on the left and the right lymphatic duct. We then would have moved on to the thoracoabdominal diaphragm and adequately treated that in order to improve overall lymphatic flow through the body. This thoracic pump can be used as a finishing technique as well, or can be used after addressing the thoracoabdominal diaphragm. In order to do this technique, I will be contacting the patient just distal to the clavicle and assuming my lunge stance. Of important note, this technique is contraindicated in patients with COPD, as there is air trapping that is already occurring. We do not want to exacerbate that. So again, contacting just distal to the clavicle with my hypothenar and thenar eminences. I will ask my patient to inhale. I maintain my pressure with the hypothenar and thenar eminences, and as he exhales, I induce an oscillatory inferior pressure, with my emphasis being on inferior. I hold this inferior pressure and ask my patient to inhale again, holding that inferior pressure. And as he exhales, I further encourage that inferior motion and pumping. He inhales again, so I'm creating a vacuum-like effect here, and exhales in that intrathoracic area. I'm going to ask him to inhale one more time, and I'm maintaining that inferior pressure. Now, hold your breath in inhalation, and now exhale all the way as far as you can. Good. Inducing the oscillatory motion. Now, this time, hold your breath in exhalation. Do not breathe in until you absolutely have to. I'm holding that inferior pressure with my hypothenar and thenar eminences. Once he takes this big inhale, I will be removing my hands suddenly to cause a little vacuum effect here in the lungs. I release and step back. And now he can breathe normally. So in patients in which this technique is indicated, this will usually give them a much greater respiratory excursion. There is generally an increase in the O2 saturation. Again, as you can see, a large volume of air was drawn into the patient's lungs and thoracic cage, and this is why this is a contraindication in patients who have active COPD. Thank you.
Let me just say a couple of things here, and then we'll stop for some discussion. If in the PowerPoint, which should be posted for everybody, if not already, there's some of the research studies that are involved in here, and particularly this second one from Dr. Knoll and the third one. These are some ones that were done on patients in the hospital with pneumonia. And some of these thoracic techniques, particularly this thoracic pump technique, was used as part of the treatment approach for OMT on these patients. And the study doesn't miraculously cure their pneumonia, so to speak, but these patients did show, for example, the patients that got OMT in these studies in the hospital for pneumonia spent less time on IV antibiotics. So which meant, of course, that they were transferred to oral antibiotics a little bit faster. They were out of bed and up and around, moving faster. They went home quicker than the patients who got all the usual treatment, but not OMT. So there was a difference there. There have been a little bit lower down. Let me see. I mentioned several studies with, you'll see Dr. Hodge, Lisa Hodge at our research center down at Texas, at North Texas State, has done a lot of research on animals using lymphatic pump techniques and has demonstrated measurable things. So they can measure the increase in lymphocytes and other immune system products during the treatments. She has shown that they've actually infected lab rats and then done the treatments and shown that the treatment helps to flush out some of the infection during the treatments. I have one study, I don't think it's in here, but there's one study, this very, very small study, they're just getting started on this, that showed the positive effect of doing these thoracic pump techniques on patients with either bed ulcers or diabetic foot ulcers. and showed some reduction in ulcers and some healing that was augmented in patients with OMT better than in patients without OMT, things like this. So there's a bunch of research involved. There are some books here that if you can get your hands on them, they have better chapters or longer chapters on the lymphatic system. My own study, I think, or my paper was listed in the study here. I did do a review paper on this and got published, and I sent it in, so it should be published on the global website for you to download if you want to read a little more in depth on this as well. And with that, I'm going to maybe stop talking a little bit and see if there are any questions or discussions.
Live long and prosper.
And, hope that we all live long and prosper a little bit with this. And let me end there, and I'll stop the screen share for the time being.
Great. Thank you, Dr. Hruby. And yeah, certainly important concept. I think also probably new to some of our audience, which some of whom came in after you started, and welcome to many of our international attendees. And so I can start with a question. We've got about 6-7 minutes specific to treating and evidence-based, as you mentioned, treatment of diabetic ulcers and other infections, especially in the extremities, and the use of these techniques having been demonstrated to provide benefit. How practical is it in the virtual environment where we have patients who are in need but can't make the trip, if you will, and bring their illness, let's say in the diabetic foot ulcer, especially for diabetics with other comorbidities, heart failure, chronic renal disease, and peripheral vascular disease, of course. For those who can't make it over the mountain range or through the river valley to the office of a practitioner who's familiar with these techniques, how practical is it to reverse the paradigm and train someone, a significant other, a paraprofessional, another clinician who's in the field with the patient to actually perform these techniques?
I would say we're on the very, very front edge of that, Dr. Pecchia, to learn that. But I can tell you that one of my own friends and colleagues back in New York, when the pandemic hit and we were all on lockdown, she actually took some of these lymphatic techniques, and she herself adapted some of them so she could treat herself, so to speak. Whereupon she made a couple of videos and put them, and you can find them on YouTube. She's a DO. Her name is Susan Milani, Milani. So if you look for Dr. Susan Milani on YouTube and lymphatic, OMT, a couple of keywords like that. And she put those up on YouTube for her patients, and she was doing a kind of telemedicine with her patients then. And the patients were using the videos, and she would get on Zoom with them and kind of walk them through this way, or if they had a spouse or somebody at home that was going to apply the technique. So, we don't like to think of being able to teach a hands-on thing like OMT by video, but under those circumstances, and DOs over the years for decades have shown family members how to do some of these techniques, especially because it's a technique sometimes if you have a sick person with a respiratory infection or something, you like to have them be treated more than, once a week or so in your office. You could treat them several times a day with a few minutes of this technique. So she was demonstrating these on her Zoom calls with her patients, and the patients were doing these treatments. And I don't know that they gathered any like big data on this or something, but it seemed to have a great effect. It certainly had a big social effect because in a short period of time, the videos were translated into Spanish, Chinese, and Tagalog, I think, and several languages. So they became quite popular with the people out there. So we know, and I read a very small study recently that somebody did in their office during that time with other techniques, just trying to show people some things. and they collected a little bit of data. I don't have it here with me right now, but showed that they had at least a small number of patients that did this with them, and they had other patients that did not do the OMT. And just based on pain ratings and functional ratings and other things that they could demonstrate, they actually got a positive statistical effect on the patients doing some of the self-treatment that way. So while we wouldn't recommend learning how to do OMT or surgery or other things by watching videos, we do seem to have the possibility that some of this can be kind of done in this way. And so we just, thankfully the pandemic is calming down. I don't know that we want to wait for another one just to try and do a research project, but if we would just do this on a more regular basis, we might gather some more long-term data that shows what kind of good effect we have. But there does seem to be some positive light on that.
Great. Yeah, thank you for that. That's very helpful. Any other questions in the couple of minutes we have left?
We have a couple questions from the chat. The first one, how do you measure the improvement in lymphatic flow?
The measurement is I don't know whether you'd call it direct or indirect. For example, you can, now with our hands, you put hands, say somebody has a swollen ankle from a sprain or something like that, you can feel the difference in tissues as you manipulate them and these types of things. You can measure those. There was one study done some years ago that was I think kind of interesting because it was done in the emergency room on acute ankle sprains. So it was only one treatment done in the ER. And prior to the treatment, they just took a tape measure and measured various parts of the foot and ankle, the diameter with the swelling. And then immediately after the treatment measured again, and they had a statistically different, statistical difference in the size and just measuring the pre and post edema state of the thing. So that's one way to do it. I saw one of my colleagues, Dr. Brusky, on the chat mentioned animals, and some animal studies have done just that. They've cannulated the thoracic duct, and they can measure the amount of flow through there. And I think that's probably something that Dr. Hodge may have done, because on one of her studies, she was showing how during the they'd have an animal sedated and do that with them, and then measure the rate of lymph flow through the thoracic duct, and then start doing something like the thoracic pump technique. And she could measure the actual increase in the amount of flow of lymphatic fluid during the technique, and then the return back to the more normal flow after the technique. So there's a couple of objective ways of measuring that. And some studies have done measurements of taking blood, for example, prior to treatment, and measuring white cells, lymphocytes, things like that, immune system products, and then doing the treatments and measuring afterwards and being able to show measurable increases in those immune system responses afterwards too. So there have been some objective studies that do that. On a clinical basis, I'll say it real fast and then leave it for other people. For example, a case, it's a long time ago, but just one case I realized, but the type of thing that can be some of this can be a real dramatic thing in a simple way. I had a patient who was a woman who had breast surgery for a tumor of some kind. I don't remember exactly what now. And she came to me 6 months post-op, and she was doing fine, except her right arm on the side where she had the surgery was still swollen, had a lot of edema in it. And of course, surgically, we know that they're going to go through and going to, cut through some of these lymphatic vessels and things in some of the tissues. And, at that time, we think, well, post-op from surgery, sometimes people have that, particularly some of these breast surgeries and things. And her surgeon didn't have another choice for her. He just felt that was a response, and we don't know how much more time it would take. I did a treatment on her where basically I opened up this thoracic inlet, if you will, on that side, and worked on the posterior folds of the axilla, and then worked along the arm, just working on the techniques through there. And she came back a week later and she was perfectly fine. No edema, no nothing, So it can be quite, quite a dramatic thing sometimes. If some of you who were on when Dr. Peche and I did a presentation about himself, some of the treatments we did were directed exactly at that, is to just restore some of that. Now, he didn't look like he was in any dire straits so long after his surgery, but he did have some stiffness in that arm that we were able to restore from that kind of thing. So it's a
Working
kind of
great.
thing that can be a real just a real boon for somebody, you know, and they're very easily learned. They're very easily transmitted. I think looks like they could be very easily transmitted to family members and things if we need to do that in certain instances. And it could be great out in the field for people to do something like this, you know, so.
You know, post mastectomy edema is a huge problem.
Yeah.
And it really worked that well, and it persisted. That's revolutionary.
Yeah, it could be really good. And
There's thousands of breast cancer patients that have that. Have there been any studies on that?
You know, I oddly enough, I don't know. And even other programs like physical therapy and others that who do hands-on treatments, I've never seen anything, and I don't know why. Because from an osteopathic point of view, my thinking would be is that if I can do that and restore the body's physiologic system, and it works that well, then the patient doesn't need to come to a center and have them put in one of those, you know, they put them in machines and things that are helpful, but it's like, it's in a way, it's a symptomatic treatment as opposed to getting to the root cause of restoring the motion. So the body's own system takes care of it rather than repeated treatments, you know. And why there hasn't been, I don't know, even in my own profession.
It's a huge and troublesome problem in surgery. So if it's really that simple, you know, it should be studied. And
at least it was in that case, that's for sure.
Right.
So,
well, you know, as we conclude, I can commit Dr. Falk and Dr. Hruby to, I'll have the university librarian actually do a search on that and deep dive and see what we can come up with.
Good.
That's a good idea. Yeah. Mm-hmm.
Yeah.
Super helpful. So we're up against the end of our hour. Thanks so much again, Dr. Hruby. A reminder to those who are going to take advantage of our pre-funded CME available to any of those who need that. That's free to you, and just follow the instructions on the website for that. And with that, I'll hand it back to Marielle to close.
Thank you, Dr. Hruby, for your insightful presentation. We are coming towards the end of our time here. This recording will be uploaded to our YouTube channel in a couple of days. And if you are interested in presenting, please feel free to reach out. Our next Global Grand Rounds will be on July 12th. And as always, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again. Thank you.
Thank you.